Welcome, everyone. It's really a pleasure to introduce our speaker today, Dr. Tim Pawlik. Dr. Pawlik has really quite an outstanding career. Started out at Georgetown and then did his medical degree at Tufts and went on to complete his surgical training at the University of Michigan, where he focused on later, after finishing that training, went on to the Mass General to focus on surgical oncology, and has really been a leader in surgical oncology, getting advanced training at the University of Texas MD Anderson Center in Houston, where he specializes in cancer of the alimentary tract, in particular hepatic and pancreatic biliary cancers. Which we all know is an area where we need lots of expertise. He also, in addition to that training, had an interest in medical ethics and completed a fellowship in medical ethics at the Harvard School of Public Health. And at the same time, if that wasn't enough, got a master's in theology at the Harvard Divinity School in Boston. So he's a pretty widely studied man here. He also, to add to that, are you ready? He got a PhD here at Johns Hopkins School of Public Health in clinical investigations. So he is well prepared to speak to us today. He came to Hopkins in 2005, and he is currently a professor of surgery and oncology. He is the director of the Johns Hopkins Liver Tumor Clinic, and he holds the John L. Cameron Chair of Alimentary Tract Diseases, in addition to being chief of the Division of Surgical Oncology. This is a busy man here. Yeah. He has given many talks worldwide. He has over 250 articles and 30 book chapters, and has served in many leadership positions. I have to say, in addition to all that, he serves on our Johns Hopkins Hospital Ethics Committee, and we are so grateful to have him be a part of our team. So I want you to give Tim a warm welcome as he speaks about disclosure of medical information to patients, risks, errors, and prognosis.
Well, I really want to thank Cinda for this invitation, and as she's mentioned, I've actually had the opportunity to give quite a few talks, I think in over 20 different countries all around the world, and I say this talk has probably caused me the most anxiety. Usually when you get asked to give a talk, you're asked to give a talk in your area of expertise, and as someone who considers himself mainly to be an oncologist, who happens to be a surgeon, who happens to operate mostly on the liver and the pancreas, I would consider those areas my areas of expertise. I have a major interest in medical ethics, and as was noted, in moral theology, moral philosophy, and that's why I went to divinity school. And so today, I hope I don't bore you with some of the banality of some of the topics that I'm going to be talking about, as I know that all of you are very well schooled in all of this. But what I'd like to share with you is a little bit of my perspective as a surgeon and someone in the clinic, and some of the issues that I face and deal with, and perhaps some of you face and deal with, and some of the challenges. And the way I wanted to structure it was to talk in general about disclosure. And the main three areas, at least in my clinical practice, where disclosure comes up is preoperatively, the informed consent, post-operatively, medical errors, because we do high-risk surgery, HPV surgery. Even though the mortality rate is less than now 3%, the morbidity rate is still 40 to 50%. So at least almost half my patients are going to have a complication. And then prognosis. I do cancer surgery. And how does one disclose prognosis in a responsible way to patients to help them frame their life expectations? So I just wanted to talk about each one of these a little bit in turn. So informed consent. So I think obviously informed consent is important in two large spectrums. One is the medical treatment, the delivery of care that I'm going to do 1:30 today when I go over to the Jayhawk and see my patients. It obviously is very important with regards to regulatory matters. But then as physician scientists, research, informed consent research is very important as we strive to improve the fund of knowledge and not only help the patients in front of us, but also future patients. And as we know, informed consent in the field of research has been riddled with a number of infamous difficulties and problems. So here's a quote to frame things. So every human being of adult years and sound mind has a right to determine what should be done with their own body. And a surgeon who performs an operation without his or her patient's consent commits an assault for which he is liable and damages. So, obviously, informed consent, the tradition of informed consent goes back many, many, many years. And this is just one paper that we wrote in the Journal of the American College of Surgeons, myself, and actually an undergrad student who was working with me, and then Pam Litz, who many of you may know, who's in the Department of Surgery. And I think one of the things that I see that still happens in surgery in particular is that we think of informed consent as kind of one process. It's not very frequently deconstructed in the clinic, if you will. And, many surgeons, and even including myself, don't really think of informed consent as being multiple processes of, informing the patient, disclosing things, and then obtaining consent. We're kind of thinking of it as just that simple sheet of paper that we get signed frequently by the residents or the fellows. So I think it's helpful to deconstruct the notion of informed consent. And to start off with, informed consent is obviously rooted in the ethical principle of respect for persons. This whole, treating patients, not as objects, but as individuals. Not something should be done on them or to them, but something that is done with them. And they need to be involved with the process from the very, very beginning. And this concept of, informed consent, the first part is obviously capacity and decision-making capacity. And, I have here a picture of a slide ruler. I think that the other pitfall that we think of is, especially sometimes as surgeons also, is that we think of someone as being capable or incapable to make informed consent. It's a binary function, that someone is either yes or no. And we look to sometimes our colleagues in psychiatry or wherever to make someone competent or incompetent to make decisions. And I think that something that I really try to foster with the medical students and the residents is to really understand this whole notion of capacity is obviously along a continuum. And patients may have the capacity to make certain decisions as part of their care, but not be capable or able to make other decisions as part of their care. And it's very much more nuanced in trying to figure out with the patient and their family what decisions can patients be involved with, what capacity do they have to participate in their care and up to what point, and make sure that they're involved as much as possible. And then also to do it within the appropriate cultural setting and also familial setting, that you're involving all of the different stakeholders that the patient may wish to be involved. So when we think of informed consent, this is, at least for me, a helpful way of thinking about it as a multi-level process, where the first part is disclosure, where the goal is to focus on the most important values and interests that are both determined by the patient and the physician. I think this is important because disclosure goes two ways. There's many patients, not infrequently in cancer, where they're facing a literal death sentence, and they want something done that I may not think is in their best interest, even though they think it's in their best interest. So it is truly a discussion. And the values go both ways. It has to be something that I can live with, and I always tell patients that I have to be able to look myself in the mirror and say that I really think this is going to help you, rather than doing some crazy operation that may be technically feasible, but in my heart of hearts, I really don't think it's going to add to the longevity of their life or the quality of their life. And it's not just a technical exercise. And it has to resonate with the values that they're articulating with regards to the goals, their life goals. What are they trying to accomplish? Where are they trying to get to? And really, it should involve not only discussions around longevity of their life, but also their quality of life and what are their goals. So I think disclosure has to be done within that context of a value system that is both patient and physician. I think the physician part, at least in my experience, can be challenging because I think sometimes that is subjective and implicit. And as physicians, sometimes it's a little bit more challenging to make that explicit, our own value system, to put it out on the table and examine that, and to understand that some of the decisions we're making as clinicians are being done through our value system that perhaps we're not even aware of, and we fail to sometimes take a step back and look at the lenses that we're looking through to make these disclosures. Because sometimes we may want to operate, and the way we disclose is shaped by that. And in other ways, sometimes we don't want to operate, and the way we disclose is shaped by that. And I've seen that. And that can be very damaging. I think the second part is patient understanding. It's very interesting, this whole say something and have the patient say it back to you, and then you saying it back to them. I think that different patients understand different things, and not even with regards necessarily to school level. We're not talking necessarily intelligence. There's some very intelligent people who have very bad problems, and sometimes it's very hard to realize that not every problem has a solution, and some very smart people want solutions, and there may not be the solution they're looking for. There may be a solution, but it may not be the one they're looking for, and that can stand in the way of them understanding the informed consent process and what we're talking about and where we're trying to get to. And I think that physicians sometimes fall short about asking these probative questions to ensure that patients really have understood. And we're not reimbursed for that, right? I mean, I hate to say it, but it's true. We're paid to go in, to make a clinical decision, to do a physical exam, to document it in Epic appropriately, and then to bill a certain level of service. And staying in the room for another half hour, 45 minutes to do this is not well compensated, especially in a subspecialty that's focused on doing procedures, right? That's how we get compensated. So in an era of RVUs and bottom line, it's challenging, I would say, especially for some of the surgical subspecialties to really engage in this patient understanding. And then finally, the patient decision-making and letting the patient analyze the information. I always tell patients, you don't need to decide now. The way I usually do in clinic is I do a lot of the informing part and leave the consent to the day of surgery. So I tell patients, we discuss, we disclose, we go over patient understanding, and then I say, you don't have to make a decision now. I'm a little bit crazy. I give people my cell phone number, and I give them my card, and I say, if you have issues, you call me, we'll talk about it on the phone. And then typically the day of surgery is when I actually obtain the written consent. And then so I give them an opportunity when they're at home where they can reach out by email or phone and have all their questions answered. And also have the opportunity to go home and talk to other relatives, their spouse or their siblings, and really kind of go through their understanding of the whole process. And it's not infrequently that I'll get phone calls from a cousin. My cousin called me and she told me you're going to do this to her, and it kind of makes sense, but we have these questions, will you answer this? And then I'll talk to the cousin, and then the cousin will talk to the patient, and actually that's a great way to facilitate getting the patient to understand, because the relative can be sometimes more effective in disclosing some things than perhaps even I can be. So this is just one study that I think is very telling, again, oncology based, but this patient's understanding of medical terminology. And this was done in the breast clinic setting. And basically the takeaway point is, if you look here, when patients were asked a whole host of questions about the tumor itself, or their surgeon, what the surgeon was going to do, or what the ultrasound showed, you can see here that many times that the proportion of patients who answered correctly was low, less than 50%. So there is kind of a mismatch. Patients don't necessarily understand a lot of the terminology we use. And also, I'm very interested also in how does one get across the notion of risk, right? Because in surgery, we're always talking about, people ask me, what is the chance this is going to be successful? And for right or wrong, I answer, I go, I don't know. It depends on what you mean. Success in my mind can be determined in two major ways. The success of the operation, getting you home and out of the hospital, or the success that you're alive 5 years from now without any cancer, because I mostly deal with cancer patients. So I don't know, what do you mean by success? And then we talk about that, and I say, well, success for the operation, here are some of the statistics. In general, the mortality, rate is, 1%. Again, the morbidity is 40 to 50%, things like that. But also the way even, I say 1%, if I say your risk of mortality is 1%, that's a lot different than saying for every 100 patients I operate on, 1 dies, right? So the way that people, you get across this notion of odds and risk, people interpret it very, very different ways. For some people, 1 in 10 chance is like nothing. They don't bat an eye because you have 1 in 10 chance of dying. They don't say anything. Other people very risk adverse. 1 in a million. What do you mean I have one chance in a million that something could happen to me? So I think that the way we talk with patients with regards to that is critically important, and also this whole idea of medical terminology is critically important, because even when you use some of the basic concepts, and I use a lot of diagrams in my clinic, a lot of drawing, things like that, to get things across, people can still misunderstand what you're trying to say. So this is just a very rough schematic, and it's always very dangerous to put things, I think, in algorithms like this, because they grossly oversimplify things that are very complex and nuanced. But I think, when we see patients, we try to establish whether they're the decision maker or not. I mean, if they are, then we can engage the patient directly. If they're not, then I think we have to identify patients' cultural identity and their explicit preferences, and this is coming up more and more. We're seeing more international patients. It can get tricky, where sometimes family members will actually want us to withhold from the actual patient their diagnosis or their prognosis, and that can be very, very challenging. We have to make sure that the patient has not deferred decision-making involuntarily, and frequently, I'll ask to talk to patient in private, and sometimes this comes up with Jehovah's Witnesses. As a patient I'm going to be seeing who needs a big liver resection as a Jehovah's Witness, and that's a very nuanced conversation. I think it's important to talk to those individuals in private. And then to maintain the engagement with the family and the other decision makers in the patient's circle of friends and family, because this will become critically important also if you don't have those relationships and the patient has a bad complication or becomes incapacitated in the post-operative period. The relationships you obviously build not only with the patient, but with their surrogate or their partner or their spouse may become very, very important in the future. Well, what about research? Research is also very important, and these two overlap frequently, where we'll be taking patients to the operating room, we'll be obtaining consent for an indicated medical intervention, but then we'll be doing some type of research in the operating room, obtaining blood or tissue and wanting to obtain consent for that. And I'm sure you're all very familiar with this story about William Beaumont, who's an Army surgeon who treated Martin, who's this Canadian fur trapper who got shot with a shotgun in the stomach, and Martin developed a gastrocutaneous fistula. So basically, this patient had a hole in his abdominal wall with direct access to his stomach. So anything he ate could be, you could put in a little string into this hole through the abdominal wall right into the stomach, and put a little piece of food on the end of it, and pull it out and see what happened. And it provided this wonderful opportunity for Dr. Beaumont not only to treat Mr. Martin, but also to do all of this research on GI gastric physiology, and actually a very seminal book back in the 19th century was written about this. So this gets into this whole idea of physicians as dual loyalties of the double agent. Double agent where I'm both the patient's surgeon or provider, but I'm also the researcher, and I need to further my career. I want to be a compassionate physician to the St. Martin's in front of me, all the patients in front of me, but at the same time, I want to be a researcher and try to secure future knowledge for future patients. And so there's this dual loyalty and conflict of interest. So I think that these conflicts aren't necessarily about right or wrong, but they can be pretty tricky. And again, I think there's a lot of subjective, implicit challenges, shall we say, as physician scientists, because some of these things are very obvious, like money, or when you have consultancies or things like that, but some of them aren't. I mean, we all want to be famous, we want to further our research, we all want to be promoted, and we all want to accrue more patients to our clinical trials. So I think it can become very cloudy, the line between therapeutic management and research. And there's been many other infamous examples of the difficulties with surgical and medical research, obviously Nuremberg, Jewish chronic disease hospitals, where we take advantage of our fiduciary responsibility to care for patients and our role as providers to leverage that into gaining additional knowledge to further our own careers. And I think surgery, to bring it back to an area that I'm most familiar with, has some particular challenges. And this is 1866, and this is Samuel Gross. He's talking about the performing of a thyroidectomy, and he says here, it'd be crazy basically to do a thyroidectomy. You'd be a fool. Look at it, foolhardy. I do not envy him. Every stroke of the knife will be followed by a torrent of blood. And lucky will it be for him if his victim lived long enough to enable him to perform butchery. So one would hope that no one describes my surgical skills in such language. But you can see here that, that in surgery it's a moving target. And it's hard to know in the operating room, what is research sometimes. When we're doing minor modifications of procedures and we're just changing maybe the suture that we're using, or a minor modification in our technique. Is that research? Do you need either approval for that? Do I need to go to the patient and consent them for that? Or the other tricky business is, which I was very fond of, because I look a little bit older now, but when I first started here, a patient told me that I looked like his paper boy. I would always get, how many of these have you done? How many of these have you done? How much of that do we have to disclose? Or now we're starting to do different procedures, like minimally invasive procedures, like laparoscopic Whipple. So you could do, how many of these have you done? Well, I've done 100. Then the patient leaves. Well, 100 open. I've done 1 laparoscopically. But they didn't really ask me how many I did laparoscopically. They asked me how many. I'm just saying, it can get very, very tricky business about how many of these have you done. What are your results, and whether we talk about our own results. For me personally, my mortality rate is this, my morbidity is this, or do I talk about Hopkins, or do I talk about the nation? So it's very challenging, I think, with regards to disclosure in surgery, how that conversation is handled. And there was actually an interesting piece in this month's clinical congress by Peter Angelos, who's a surgeon and a true medical ethicist at the University of Chicago, with the other question that always gets asked: did you have a good night's sleep last night? That's patients they're very spooked about that. I don't know, but they are. Did you have a good night? And I have 4 kids. And most of the time I had a good night's sleep. But I mean, you talked a little bit in the article, do we disclose that? And now it's a little bit better with the 80-hour work week and restriction of our hours. But I can tell you there were many times when I was up all night doing non-trauma emergencies as a resident, and then, come in here at 6:30 in the morning and try to do a 6-hour elective case. And, it was one time where, I have kidney stones. I had a horrible kidney stone attack. I had a Whipple the next day. And I was in the ER till like midnight. And I was like, what should I do? What should I do? And I'm just calling the patient at midnight saying, I think it's a bad idea for us to do this operation tomorrow. We're going to cancel it and we're going to reschedule it. But I think those are challenging. And then the other thing that just came across my mind when we talked about, the other thing, not really related to this, but I'll still tell it, it's kind of interesting, is will you pray with me? Because they see the divinity thing. And some people say to me, oh, that's good. People come to me and say, I picked you because I think God's at work here. I saw you went to divinity school, and they want to engage you. And will you pray with me? And that's a very interesting topic. We're not getting into it, whether you should do it, even if you don't believe it, or you should do it. And it's a very tricky business. But getting back more to this. I think, minor modifications is like tinkering. If you're just changing a little thing, maybe the suture that you use, innovative procedure, something that's new or modified. But then, surgical research, and, I don't know, doing procedures like this NOTES, I don't know if NOTES is this, minimally invasive thing, like here we removed a kidney through a woman's vagina. She had a prior hysterectomy and through the vaginal cuff, we went up and, removed, donor nephrectomy, she was donating a kidney, and is that research? Does that need IRB approval? My understanding it wasn't IRB approval for it, but it was a full disclosure to the patient. It's tricky business. So, the tension in research, is always that, we don't want to prevent patients from getting better treatment because of restrictive oversight, but at the same time, we don't want to expose patients to greater risk. And probably, at least in my memory, the greatest example of this was probably with HIV, and all the advocacy that was done around AIDS and HIV. There was this, this great advocacy that was done about we need to move faster with clinical trials. People are dying of HIV, and we need to get these drugs out there so people can be taking them. But this is the constant tension. And then two kind of comical quotes. As long as you promise not to learn anything from what you're doing, you don't have to get an IRB approval, right? As long as it's not research, you're not going to learn anything. You don't need IRB approval. And the other one was, why is I need permission to give a drug to half my patients, but not if I want to give it to all my patients? So that's the other things we frequently do, right? Is we use things like off-label or not as FDA approved, or if we even use a new technique, use a new device, I just say I'm going to introduce it into my practice and I'm going to use it for everybody. That's okay. But if I'm only going to introduce it to half my practice and the other half I'm not going to introduce it to, and then I'm going to study it, then it's a research question. So that's can be kind of odd and kind of contradictory. So. Now obviously we're kind of ruled by this common rule. There needs to be institutional accountability, IRB review, and obviously informed consent. Informed consent, as we already talked about, there needs to be a good risk-benefit ratio, protect the patient's confidentiality, and there needs to be scientific validity. And I think that's another thing that sometimes comes up in surgery is that surgeons are always rightfully so maybe picked upon for not being scientifically rigorous as our medicine colleagues. And I think it's important that if we're going to enroll patients in research or trials, that it better be scientifically rigorous, and that we're going to answer a question, and that it's going to actually impact care. Because even if it's minimal harm, if we were doing something that isn't scientifically rigorous, we're wasting time, we're wasting resources, and we're wasting opportunities for patients. So we need to make sure we're scientifically rigorous. And then the other thing that comes up, in particular oncology, is this phase 1, and this whole term that's been coined is therapeutic misconception. I think is very tricky business in oncology. You see patients who have cancer who have gotten first-line chemotherapy and failed it. They've got second-line chemotherapy and failed it. Now they're going to go on to a clinical trial. And there's this persistent therapeutic misconception that patients think that a phase 1 clinical trial, in some sense, is holding out some hope of therapeutic benefit to them. Now, it may, I mean, it's lightning in a bottle, but that's not the purpose of a phase 1 trial, right? The phase 1 trial is not meant to be offering necessarily therapeutic benefit to the patient that is enrolling in that trial. And I think that I think we fall down on that sometimes in the way we explain that to patients and help them understand what that purpose is. I'm going to skip that. So medical errors. So that was kind of my view on preoperative issues among surgery. And then the other thing is kind of post-op or intra-op medical errors. And I got interested in this because I heard this story that didn't happen here, thank goodness, but I was at a meeting and someone was very disturbed because they were in an operation, laparoscopic, minimally invasive, and during the case, someone made an enterotomy, made a hole in the intestine, but inadvertently. I forget what they were doing. Let's say they were taking out the gallbladder and they made an inadvertent hole in the intestine. And they sewed it up. So the attending physician said to the resident, pretty much, I forbid you to bring this up to the patient. No harm, no foul, right? We made a hole, we closed it, no problems, non-harmful error. She's a nervous person, don't go worrying her, it's going to be okay. And the resident was very bothered by that. Was very bothered by that, rightly so. And so this kind of percolated at meetings. People were talking about it, and then because of that, we kind of got interested in thinking about non-harmful medical errors. And as I'll show you, with Albert Wu, we wrote a piece for JAMA Surgery about medical errors. And here it is. So disclosure of non-harmful medical errors and other events. So that's why we got interested in that topic. These slides Albert Wu shared with me, and I really want to thank him. Because of my anxiety doing this talk, he was going to do it with me, but he had a conflict, but he was generous enough to share his slides. So, I think adverse events will always happen. I always tell patients, people cross the street, and sooner or later, somebody gets hit by a car, right? Somebody gets hit by a car. So nothing is, without risk, especially in surgery. I would say there's no such thing as small surgeries, there's only small surgeons. Right? So, but everything has risk, everything has risk. So I think there needs to be a systematic and principled approach to handling adverse events. And the important components are obviously is disclosure to the patient family, dealing with the second victims, which I'll go over, and then learning from the medical errors. So what do patients want to know? Patients know that safety is an issue, and many of them have experienced an incident either themselves or in their family about an error, whether it's a communication problem, disrespect, lack of compassion or caring, or medical error. And as I'll go on the show, I think we have to kind of reconceptualize what we think of as a medical error. Medical error just isn't giving like too much potassium or having a wound complication, but a medical error, at least in my mind, involves the whole experience. Communication errors, perception errors, not being kind or compassionate to the patient. That's a medical error. That's a medical error, and that's what patients experience, right? That's their experience, so that is an error. And until we broaden our concept of what an error is, then we're kind of going to devalue those other things, which are obviously important. And we're very technically focused as surgeons. It didn't leak, so there's no error, right? But everything else about the medical experience, the hospital experience, was horrible, but it didn't leak, so there's no errors. So, when we think about different types of medical errors, there's the near miss. The unsafe conditions, the event didn't reach the individual just because of chance alone. It's like the whole airplane things. The non-harmful event, as I mentioned, my example, making a hole in something and sewing it up. So ultimately, it didn't cause the patient harm. Obviously, the issue is if it does leak on day 5, you're going to have a lot of explaining to do. Instead of just starting from the beginning saying, look, we made a small hole in your intestine. I'm very sorry about that. We sewed it up. It's highly unlikely this is going to cause you any untoward complications, but I just want to let you know. So that way, there's no surprises. If the thing leaks on day 5, they're ready. But if it leaks on day 5 and you haven't prepared the patient or the family, then you really set yourself up. And then harmful errors, which I think everyone agrees needs to be disclosed in a very timely manner. And then death, which I will talk about in a second. So for patients, I think there's a lot of anxiety when errors, physical, emotional, and then also financial. If there's a big complication sometimes, they're worried about, my wife's been in the hospital for 40 days. You said she was going to be here for 7 days. Who's paying that bill? And you have to, pay attention to those issues, and sadness, anxiety, frustration, guilt, and also, just worry about further harm, this kind of eroding of trust, that if you've made one error, can I trust you not to make more errors? And I think some of that trust is how you handle the initial error, right? Because if you handle the initial error poorly, then you've completely undermined the entire relationship. And they're not going to trust you. They're not going to trust you. But if you handle the error in an appropriate way, I think that people are very reasonable. And if you've done a good job with the informed consent, that's going to help also, because it's kind of a seamless process. So patient needs for coping, they want care, they want support, and they want to know. They want what happened, how did it happen, and why did it happen, and be honest about it. And try to use the active voice and not the passive voice. A hole was made in the intestine. No, I made a hole in your intestine. Take responsibility, take ownership of it. That works much, much better. And, good communication. Try not to be, very emotional about it. Try not to blame people. Don't be evasive, because all that causes more stress. You know, professionals are conflicted. You know, it's very, very difficult. You know, we you know, think that we should disclose, and we kind of know that we should disclose, but we're concerned. You know, we're concerned about, you know, our reputation. We're concerned about liability. You know, we're concerned about institutional ramifications. And then there's also, you know, personal barriers. You know, it's kind of crazy, you know. I think that, you know, someone comes in, you meet them once, and the next time you see them, they're basically naked and you're cutting into them. You know, there's a certain type of personality that lends itself to that. And, you know, confidence is one word. You could probably think of a few other synonyms that go along with it. But it's difficult sometimes for us to admit mistakes, right? Because it's hard to get back on the wagon. You know, if you have a bad complication one day, but your OR is booked the next day, you know, you get back on the wagon. And, you know, they say, you know, in medicine, you know, it's a little bit, I'm kind of being a jokester here a little bit. In medicine, it's a little bit God's fault, or it's nature's fault. You know, someone has CHF, and like, oh, you know, it's kind of like, what happened? You know, in surgery, it's more, who did it? Who did it? You know, it's like, there's a smoking gun. You know, I did it. You know, because I was operating on the patient. Now 3 days later, the thing's leaking. There's no one to blame but me. And so I think it's very hard to take ownership of that, to process that, to find a place for that, and not ignore it, but let it not at the same time rule you. Because if it rules you, you can't get back on the horse. And I know some surgeons who have had very bad complications and now no longer operate because they couldn't deal with it. And then again, the institutional barriers. And again, you know, avoid this whole spin, you know, disclose and accept responsibility. You know, this partial disclosure, as I mentioned, is classic. You know, you describe the incident but not the harm that it caused, or you imply the harm was caused by disease or something else, and you describe the bad outcome but not the incident. So you say, oh, you know, something happened, or, you know, but you don't say, you know, it's because I made the hole in the intestine. And then the whole idea of like not apologizing, I think, is problematic. You know, different countries deal with this different ways. You know, I think some of this is cultural. You know, these are gross generalizations from the literature, but in different countries, you know, maybe not the exact details or nothing, or don't tell the patient, tell the family member. But I think, you know, in the United States especially, I mean, people have a clear expectation that they want an explanation, they want to hear a description, and they want to hear what steps are going to be taken to avoid this. And I think this whole idea of an apology is really important. So here's the policy for medical disclosure here at Hopkins. You know, prompt reporting of medical error in good faith, and it will not result in punitive action. I think that's key. You know, this fear of being penalized by the institution is not real. You know, I think that, you know, the policy clearly states that we're encouraged to promptly report medical errors, and it's the right of the patient to receive information. And obviously, this is a lot easier when you have the errors that cause clear harm. I think, you know, it gets a lot grayer when these like non-harmful. You know, that's where we always rationalize. Well, it didn't really cause harm, so why do I have to tell them? Type of deal. But at least in the article that we wrote, Albert and I, you know, we obviously make a pitch for full disclosure of everything, because I think that's what's going to lead to the best trust. So here, again, the dreaded algorithm of, you know, recognition of the incident, if there's harm, then you need to disclose and act to mitigate the harm and then continue patient care. No harm, you know, it says discretionary, but I think that even in you know, most instances, and obviously, you know, the pushback people get with like, well, you know, if you try an IV and you cause like an ecchymosis and then you move to the next site, you know, is that, you have to disclose, you know, that you know, like how much is no harm, you know, and you have to use your judgment, you know, if, but I think in general, it's better to err on the side of full disclosure, and then you are able to set the context and to kind of set the story, rather than being on the other end of it and the tail wagging the dog. The other thing that's super important is, you know, even with these near misses, disclosed to the patient, but it should be disclosed to the ward, the floor, the institution, because these are our opportunities to avoid real harm, obviously. And when we are shy about disclosing near misses or non-harmful errors, we miss an enormous opportunity, not only a pedagogical opportunity to teach the residents and the students, but also to learn as an institution how we can better our systems and processes of care to avoid real harm errors. So I think, be timely, make it part of the patient-provider relationship, be empathetic, and the last thing is this apology. I really think that someone should say, I'm sorry, I'm sorry. So the other story I tell is my mother recently had a knee operation, arthroscopic surgery, and it was about 2 months ago, and didn't go well. Didn't go well. Her leg is massively edematous, and she can barely walk on it. She has a cane. So she went and got another MRI, and the radiologist said, your knee's a mess. Your knee's a mess, and that other guy, he's horrible. You never should go back to him. And so she's getting a second opinion. And my mother, I talk to my mother like every other day. Maybe I'm my mom's boy. I talk to her a lot. All she cares about is, she said, for a surgeon, she goes, all I want is for that guy to call me and say he's sorry. I mean, that's all. She's been 3 months on a cane, her leg's horrible. I don't care about anything else. All she said, if that guy, she goes, I'm not calling him. I'm not calling him. But he's got all the records from this other guy. All he has to do is call up and say, I'm sorry. And I just think that just those words, we don't want to say them, but we just say, no, I'm very sorry, that this happened to you, and and I want to make it better, but I take ownership of it. And then this is an article that Albert wrote right here about some hospitals in Massachusetts that are trying to put a policy into place about helping physicians make apologies. How do you do that? Because a lot of us aren't skilled in doing that. It's a very awkward conversation. And this has important implications even with risk management, because there are some data that suggests that saying you're sorry and really apologizing to patients and meeting them about this issue substantively can result in lower liability payments and decreases in physicians getting sued. And I think that's the case with my mother. If the guy just called, it would make the situation get a lot better. The other thing is, the second victim. The second victim is the providers. And, I think that, we are trying always to help patients, obviously. And it goes without saying that when we make mistakes and we cause harm, I mean, it bothers us. And here's an article that Albert picked out, and this is a horrible example of a critical care nurse who inadvertently gave a fatal overdose to a baby in a NICU, and then subsequently she took her own life because she couldn't live with it. So I think that the whole second victim is very important. I can speak to this personally, as a surgeon, and many people don't talk about this, but I mean I believe you got to talk about it because it's important. I had one of the most traumatic experiences I think any surgeon can have, which is an intraoperative death, which is a horrible experience that I've experienced once in my life, probably I think about 4 years ago now. For something, I don't know what it is, but patients who die post-operatively, it's very different than having someone die in the operating on the table. And I had an experience 4 years ago doing a major liver resection. It was taped. Hopefully the legal law was one of them talking about this case. But where we got into trouble, and we called all the appropriate people early enough. Come in, a bunch of senior surgeons in the room, but the patient ended up dying. And I can tell you from personal experience that I went to FASA. It was very, very challenging. I mean, get choked up now on it. But it's a very challenging experience. And I could say for the first 3 years, there wasn't a day that went by that I didn't think about that patient. So, I mean, I think we need to have all the right things in place. And I'm sorry about that. It's just, it's something that still, even 4 years ago, is very difficult to talk about. But I think we have to take care of people like myself, because clearly I need help here. I'm the basket keeps falling apart. But we do need to find places the health providers. I mean, that was a very dramatic example of someone dying in the operating room, but I think that even other examples where we make medical errors that aren't as big, and I'll tell you something comical because I'm withering like a fool. My wife is a nurse, and she doesn't practice anymore. But when we were in I was in residence, she was a nurse. She came home one night, and she was very upset because she put the wrong type of lubricant on the NG tube that she was putting in, and she was beside herself. I don't know, she put like something. It was like no big deal. You know, it's like she put like water soluble, but it was like oil based. It was like nothing to me. I was like, are you kidding me? You know, I mean, I was like, but to her, she was very, very upset. So I think that's the other thing, you know, the different people, you know, we all take our job seriously. So in my mind, something, you know, that may be not that big a deal, someone else may really struggle with that, And we all have to be open to where people are at, and, you know, when they make errors, how can we help them deal with that? How can we help them have resolution with that? I'm going to skip over that. So the last thing I'm going to want to talk about is more, you know, not the post-operative, but like the long-term disclosure. The thing that I grapple with is prognosis. And I think this is really important. I had a junior faculty member call me the other day, and he was struggling with, you know, talking with a patient and their family member about the patient's prognosis. And, you know, he had told them, you know, 6 months, and I'll get into it, but I typically don't give numbers. I don't like numbers, because if you tell someone a number, my general opinion is, A, it's wrong. It's going to be wrong, because we don't really have data. I mean, we have range and things like that, and people become fixated on a number. As soon as everything else stops, and the whole conversation when you try to talk about prognosis or life goals or anything, when you give a patient a number, say, you know, you have 3 months to live, all they hear is 3 months to live. And it's a showstopper. So I usually do not give patients a number, but it can be challenging about how to deal with this. And these are 2 articles that recently were published, and we did an evidence-based review of this one article for the surgical residents. There's a program here in the United States and Canada where a group of surgeons pick articles, and then we do like a rigorous methodological review of the article, and then highlight the article to be read by surgical residents in Canada and the United States. And I was very pleased that we picked this article, which was a non-surgical article. And it's patients' expectations about effects of chemotherapy for advanced cancer. And then the same group published one in JCO looking at expectations for radiation therapy. And, you know, this is some real, I think, eye-opening stuff. So these are patients who have stage 4, clearly unresectable, incurable colon cancer and lung cancer. And everyone should know that. The provider knows that, and the patients allegedly know that, and they're enrolled to get chemotherapy. And they then ask the patients, you know, what is the likelihood that the chemotherapy that you're receiving is going to cure you, that it's going to extend your life, or it's going to provide you systematic relief. And, you know, a lot of bar graphs, but the bottom line is that 69% of patients and 81 of colorectal patients did not report understanding that chemotherapy was not at all likely to cure their cancer, right? So that is problematic. You know, a large majority of patients who are getting chemotherapy that is designed to be palliative, right? Maybe prolong their life and maintain a quality of life, but it surely is not going to cure them. And, you know, this New England Journal of Medicine paper, you know, 78% of patients think it's actually going to cure. So it's clearly a disconnect. So either, in my mind, the physicians are doing a very bad job or poor job talking things over with the patient, or the physicians are doing a great job in just that patients, you know, are having difficulty, as I kind of alluded to before, hearing that there's no good solution. There's no solution that is going to result in cure. And if you look at some of the factors that were associated with inaccurate response, you know, colorectal cancer patients were more likely to think it was potentially curative, perhaps because we have a slightly better chemotherapy, I think, for colorectal than for lung cancer. And then the other thing was that the physician communication score was associated with it. So, how well the patient graded their physician as far as being a communicator impacted, whether the patient thought the chemotherapy was going to be curative or not. And then the same exact pattern held with radiation therapy. Again, 80% of patients believe that radiation therapy was very or somewhat likely to help them live longer or cure them. So this big disconnect. And then finally, not surprising, the people who got chemotherapy and radiation therapy, they strongly correlated. If you thought the chemo was going to be curative, you thought, you were all in. You were all in. You thought that this therapy was going to be curative. So, I don't really have the answer to that. This is just actually something that I've been thinking much more about over the last, maybe 2 to 4 to 6 months, because I find it's coming up more and more, especially in cancer, because I think now with more effective chemotherapy, I tell patients that we're turning many of these diseases into chronic diseases, like colorectal cancer. If you look at colorectal cancer, stage 4, when I was a student, the 5-year survival was in the range of about like 30%. So now the 5-year survival for metastatic colorectal cancer is about 50 to 60%. So we've doubled the 5-year survival. So we all go around and pat each other. But at 5 years, the recurrence-free survival is still only about 30%. So 2/3 of patients will be alive at 5 years, so that's great, but they're going to have disease. So we're turning this more into a chronic disease. And I think as we do that more and more, this whole conversation about cure becomes trickier, I think, because I think that the cure is still elusive. And I tell patients that we're turning this more into like diabetes or hypertension. We're going to manage this disease. And do people live a long time with some of these diseases? Yes. But do those diseases adversely impact on your life and perhaps shorten your life? Yes. So, I don't know if, you're going to die from colorectal cancer. And the other thing is, you talk about 5 years, we're not to be facetious, but, at 5 years, you're not 60% alive. You're alive or you're dead, right? So how do you translate population-based statistics to the individual, right? So, I tell patients, either you're going to be alive or you're going to be dead. We're counting on that you're going to be in the alive category. We're going to do everything possible to get you there. But it's very hard for them to understand, because that doesn't make sense, right? It doesn't make sense. So there's definitely this information spectrum on the information that we give patients and also how patients experience it. And our own Lily Shockney, who's a national and international advocate for breast cancer here at Hopkins, as I mentioned, all around the world, wrote this very nice piece that I found about communicating with patients on the treatment for advanced disease. And she talks about how to engage patients, ask the patient, how much do you want to know about your cancer? And I was just mentioning earlier, before we talked, the first thing is a junior faculty when I came here 8 years ago as a surgeon, I assumed that people were getting referred to me because they had cancer and I was getting referred, I was going to take it out. And I quickly learned that many patients who were referred to the surgeon don't even know they have cancer. They were referred for a spot. Someone told you, why are you here today? I have a spot. No one's told them you have cancer. So it was a rude awakening to me. I was jumping in midstream saying, okay, I know you have cancer, and I'm here to think about taking it out. And they're like, what are you talking about? I have cancer? And I'm like, no one told you. So I think that, we have to ask patients, where you are, what is your understanding of this? And then also, what is your expectations? Is your expectation that you're going to be cured of this forever and ever? I don't know if I can get you there. I always have to say it that way, but can we manage it? And can I operate on you? And hopefully, it will stay away, but it may come back. And, we all have to know what we're up against and what we're in for, and provide patients with a very frank, honest conversation that's a two-way conversation that lets them articulate what's important to them and what are they hoping for. And I always say, it's like fetal care. It's a tautology in some sense, because you can't define whether something is futile. Something, in my mind, something's only futile in relation to a goal you're trying to achieve.
So we first have to identify what you're trying to achieve. Then we can talk about whether, is it futile? Because it may be futile if we're trying to achieve cure. It may not be futile if we're trying to keep you alive and with a good quality of life for 3 months because you want to see your daughter get married. Then that's not futile. So, and I think the same thing goes when we're talking about some of our surgical interventions. We have to set the stage. And, for me, and I tell the residents and medical students, it's this balance. You want to be honest with people. I've had a couple patients recently, actually, who were referred to me as a surgeon, but I couldn't operate on them. The disease was so advanced, and then they get admitted to my service, and then it's as a surgeon, they're on my service. I've never operated on them, but they have advanced disease, and so we're trying to navigate that. And it's provided some good opportunities to talk to the residents and the medical students about these conversations, because you don't want to, I don't want to destroy people's hope, right? You don't want to be the boom, so to speak, to say all is lost. This is it. It's over. That's not appropriate. But at the same time, you want to be realistic with patients and say, this is probably going to take your life. I don't know when. It's your body, it's your life. You need to know so you can plan appropriately. So you need to balance this idea of giving people hope, and then also being realistic and finding this common ground of meaning. People, I think we're all striving to find meaning, right? We want meaning, comfort, and peace. And how do we achieve that in these communications? So with that, I'll conclude. And what I've hopefully tried to do is, just talk a little bit about this notion of disclosure and look at it through the 3 different lenses of a surgical perspective. The kind of the pre-op, the informed consent, how it's an active process that involves not only disclosure, but the assurance of understanding of information on the patient's part, and then probably the least important thing is having the patient sign the document. From our perspective, from the legal perspective, it's probably the most important thing. From our perspective, it's maybe the least important thing. The research consent and some of the pitfalls involved with that, and then just this concept of just being open with the patient with regards to medical errors, whether they're harmful medical errors, non-harmful medical errors, in using the disclosure of medical errors not only as an opportunity to make the relationship with the patient deeper, because I think it is an opportunity to do that, to build even more trust, but also to help the institution learn from that so we can treat future patients better and safer. And then finally, with regards to prognosis, I think this needs to be done in an open and straightforward and honest manner. And I think that there is some research, hopefully that will be being done about tools that can be given both to providers and patients to help them with this process of disclosing prognosis and what questions should the patient be asking and what information and questions should the provider be asking of the patient so that information can be get across. Because I think ultimately that's what people remember, right? People, I know it sounds kind of corny, but it's true, but no one ever remembers, let's take a surgery, right? So the big thing about surgery, people just care about their incision. You could do like 8 hours of work inside their abdomen, but then they look and say, oh, that's a nice incision. Right? So I think here, it's what you leave them with. It's what they can see. It's what their experience is. And I think, at the end of the day, that's the most important thing. It's not, all the surgery we do. I think that is important, but it's going to be, what do they leave with, and how compassionate and caring are you, and especially around issues of death and dying. People remember forever. That's like transgenerational, right? People remember how they were told that their father or mother were terminal, or how they were going to die. And we need to do better providing more accurate information in those circumstances and doing it in a caring and compassionate way so that can be a meaningful experience both for the patient but for the entire family. So again, I want to thank you for this opportunity, and I really want to thank Albert, who couldn't be here in person, but through his slides was here in spirit. So thank you very much.
So I'm do, and then I think Tim might have just a couple minutes after we finish to chat for a minute. Okay. So, questions, comments? Tim?
So thank you, Tim, I really appreciate your openness and honesty. I actually have a question about the culture, the surgical culture, and this particularly have an interest in this idea of the second victim, and your very poignant experience. Since I'm sure you're not the only person who's ever had that experience in surgery, is there a system in surgery? Is the surgical culture discussing how to support each other when that happens, or is there silence among your colleagues when that happens?
I don't think there's necessarily silent. I think it's getting better. I think the culture within surgery has dramatically changed over the last 20 years. I think here a lot of that was because of Julie Freischlag. I think Julie has ushered in a whole new surgical culture of openness. Those of you who know Julie, you couldn't find a more open, more forthright person. So I think she has strongly encouraged that. I think, when this happened to me, there were the processes in place where I could get some help. When I went FASA for a few weeks, I talked about it, and my colleagues were very open about it, and I was able to talk with them. But people handle it differently, and I think a good example is, I was asked to write a book. So we're editing the book, we're going to write a book, and the book we're going to write on is surgical complications. So I'm writing a book right now, and basically it's really bad complications. That's what the book's basically about. And how do you get out of it? And so I'm asking famous people, here's a bad complication, and I want you to write about how to avoid it, how do you deal with it, et cetera, et cetera. I wanted to include in the book intraoperative death because of my experience, because I figured it's something that should be dealt with. No one will write the chapter. You ask, no surgeon wants to put their name on that book, and I've asked people, nobody wants to do it. I have to credit Murray Brennan, who, I don't know if you know, he's the former chief of surgery at Memorial Sloan Kettering, and now is in his mid to late 70s and retired. He's going to write a book, I'm going to write a chapter for the book that's going to incorporate that. So he was nice enough to incorporate that into his chapter, which was on Breaking Bad News. But nobody wants to talk about it, you know what I mean? And it needs to be talked about.
Thank you. So much of your talk revolves around disclosure of language, and I wonder what your experience has been about the choice of different surgeons and their level of training of what specific language they use when it comes to event-free survival, progression-free survival, overall survival, etc., 3 or 5 year, and how have you noticed that there's different surgeons at their different levels of training, how that correlates to patients' understanding and things of that nature?
I haven't. I think my general sense is that we pretty much talk about overall survival. And that's why, I've had some interest in disease-free survival. And we've written a couple papers looking at colorectal cancer. Because the impression I got going around the country and the world talking about colorectal cancer is that surgeons were knocking each other over with all the backslaps about doubling overall survival. It's a great success. But then, there's another part of the story, like I said, which is the disease-free survival that needs to be looked into. But I think in general, we talk about overall survival. And I don't know, but it would also be interesting to look at the way it gets discussed based on years in practice and also training. And I don't know, but as someone, as I mentioned, I consider myself an oncologist who happens to be a surgeon. So I take very seriously those types of conversations, and I don't know whether the way someone is trained also impacts that.
If I can tell you, as a pediatric oncologist, I actually focus more on event-free survival. If I've got a 5-year-old kid, I need to make sure that the kids, they may relapse 3 years down the road, and that's going to have major impact on that child and family's life, whereas overall survival, of course, is ultimately
Exactly, I mean, I think exactly. I think, at least from my perspective, I'm not that familiar with this literature, but it seems like this is only the tip of the iceberg. I think there's a lot of work to go with disclosure of prognosis, especially on the part of surgeons.
Thank you.
So I know we have lots more questions for Tim, but let's thank Tim again for being here.